think and teach how to describe the skin exam features, because that's really the key and basis to dermatologic diagnosis. So we're going to spend a little bit of time talking about the skin exam and how to describe lesions. There's also a website that you can use that's an open tutorial on the skin terminology. So that's called Learn Derm. If you simply Google Learn Derm, you'll come to the self-paced tutorial that you can do at any point. I highly recommend it. It's very visual. It's a lot of fun. It has a quiz at the end where you can quiz yourself. The bulk of this presentation will be dermatology top 10, kind of after David Letterman's top 10. So this will be highlighting some common mistakes in dermatology that we think are important to primary care dermatology, whether it's in the family clinician's office or in the retail clinic of the little clinic. And last, I'll complete with some tips on VisualDx. So let's move right into the skin exam. So I know that time is short and of the essence. We do recommend that you have adequate light in the room. It seems obvious, but sometimes we're not illuminating the patient so we can see the subtle differences in things like skin color on the exam. And we have in dermatology clinic time to put patients in a gown. I'm just not sure how you work that at the little clinic, but sometimes you'll discover hints on the back where the patient comes in with a lesion on the arm, and there's some clues on the back, or chest. So it's helpful often to look in other areas than just the exposed skin where the problem might be. The other thing that's critical to dermatologic exam is to feel the lesion. And in addition to tenderness, you can feel the thickness and often have a sense, is the lesion superficial, suggesting that it might be an epidermal problem, something high up in the skin, or does the lesion, when you palpate it, feel thick or deep and have more of a dermal or subcutaneous feel to it? So use your fingers. And then hopefully you have a magnifying glass or something called an episcope where you can illuminate and magnify at the same time and really see more clearly into the skin. Scraping with the edge of a glass slide or a blade to get at scale is an important feature of the skin exam, as well as measuring. So when you chart your patient, it's really important to measure lesions and put it in the record. And then there's a technique called dioscopy, which means looking through, which you're going to press with a glass microscope slide or with your finger to see if the skin blanches. And that's important because when blood leaks out of blood vessels, it causes purpura. And I'll spend a few minutes on purpura because it's an important sign not to miss, where you'd probably want to refer the patient if you saw that sign. So I'm going to spend a minute or two on that in just a few seconds. So we categorize what we see, and it's really important not to call what you see a rash or a lesion. It's important to describe using the fundamental terms of dermatology. So if you remember, flat lesions are either macules or patches. So these smaller lesions are macules, larger than a centimeter is a patch. Raised and smooth lesions include nodules and papules and plaque and cysts. These would be lesions that have substance. You feel with your finger, they're raised off the surface. And when you close your eyes and you rub your fingers across the skin and you don't feel anything, it's only a color change, that's a macular patch. If you feel it to be raised, then you're going to be a papule, which is smaller than a centimeter, or plaque, which is larger. Nodules have substance and depth. Cysts can be compressible and also tend to be a little bit deeper. We describe surface change, so we could say the plaque is scaly, a scaly plaque, scaly papule, or a crusted papule or plaque. And then lesions that have fluid in it, such as pustules and vesicles and bulla. So the analog, again, of this small is vesicle, larger than a centimeter is a bulla. Of course, pus-filled fluid lesions or pustules. And then lesions that are flat in pink or red are in this blanchable category, such as erythemas, which include body-wide redness. That's usually a medical emergency, so I'd expect you to refer somebody if they had complete body redness, and that's called erythroderma. But you could say there are erythematous macules or erythematous patches. Those would be blanching, flat lesions. And then also telangiectasias that are small, fine blood vessels. They also blanch. I mentioned purpurs. Those can be serious because you have blood leaking out of vessels. So a simple bruise is called an ecchymosis. And we have petechiae, which are pinpoint, and then palpable purpur. And finally, there are lesions that are in the sunken below the surface category, which include atrophies, which are thinning of the skin. And you could have a very superficial atrophy, like an epidermal atrophy, or a deeper atrophy caused by the dermis or the subcutaneous tissue thinning. And then, of course, when you lose the surface of the skin, if you just lose it superficially, that's an erosion. But when you lose the entire epidermis, and you're into the dermis or subcutaneous tissue, that's an ulcer. And then I mentioned the purpurs, and just a little bit more detail here is two photos of different types of bruises. Of course, bruises go through that stage of healing where initially they're red and purple, and over time they become green and yellow and fade. And so the purpuric lesions, ecchymoses, are simply bruises. More serious are petechiae, where you have little 1 to 2 millimeter pinpoint hemorrhages, pinpoint macules. These are flat. They're little teeny hemorrhages in the skin, usually due to platelet dysfunction or thrombocytopenia, lack of platelets. They can be a sign of serious disease, such as diseases like Rocky Mountain spotted fever or even meningitis. So if you had a patient with lots of petechiae, that also is worth a referral. Similarly, palpable purpur, very important skin exam finding. These are raised, bloody lesions where blood is extravasated into the skin. You can push with your slide or your finger, and these do not blanch. So these are raised, non-blanching lesions, and they can be a sign of vasculitis, also a good reason to refer. So let's go to common diseases in the dermatology top 10. I want to share some pearls. It's that time of year for poison ivy, and of course, poison ivy has a lot of myths around it. I want to dispel some of the myths and talk about treatment of poison ivy. So, of course, poison ivy, when you brush up against a plant or you innocently, as a patient, move the antigen, the allergen, with your finger across the skin, or the plant has scratched your skin, you'll get these linear plaques of poison ivy. And you could have linear vesicles or bulla. You can have erosions, scale. So this is a classic dermatitis type of presentation. And, of course, poison ivy itches, and sometimes it's widespread. So here's a child that had poison ivy all over the face, causing erythema and edema. And the edema was significant, so there's some oozing and then crusting over a couple-day period. And so there's a picture of the plant. Remember, there's 3 leaves. If you're in the West, California and the Pacific Northwest, they have poison oak, not poison ivy, but it's the same allergen. So the allergen gets on your skin, and then 2 days later, the patient breaks out with the rash because it's a delayed hypersensitivity reaction. Now, the teaching pearl is never prescribe a Medrol dose pack for poison ivy. The proper therapy for severe poison ivy is a 4-day course of oral prednisone or intramuscular Kenalog. And the reason is that poison ivy is a delayed 4 hypersensitivity reaction. This allergen is triggering your immune system and is peaking at day 6 or 7. So right when that Medrol dose pack is ending, the allergic reactions peaking. So in dermatology, we frequently see patients that are rebounding. So initially they do good in the first couple of days on that dose pack. When it ends, they think they've been reinfected or they're not sure why it's back, and they show up in our office. So the tip is, if they have widespread poison ivy, pull out your prescription pad and write for prednisone, depending on their weight. Start at 1 milligram per kilogram, and then titrate that over 2 weeks, and don't do it over 6 or 7 days. So the next in the dermatology top 10 is some teaching on antifungal and steroid combined therapy. So let's take a look at some pictures. Here is a fold, and what you'll see in the fold is you're going to see some erythema, and you actually can see the blood vessels coming through. And so this is a shot of the epidermal atrophy where a potent topical steroid was used in the fold. And so when you apply a potent topical steroid and you cover it, or you put it in a fold like it's covered, it's going to penetrate a lot faster. And so I'm showing you pictures here of the atrophy of the skin, which is permanent damage. And so these are stria, atrophic stria, from using a high-potency topical steroid long-term. And here's another picture of stria. So lotrozone, which is frequently prescribed, is a combination of an antifungal and a very super potent topical steroid, betamethasone. These are high-potency corticosteroids. You really, what you're trying to do when you prescribe lotrozone is cover both bases. You want to kind of treat for fungus, treat for dermatitis, and it can result in a couple problems like steroid atrophy, but it also prevents you from really figuring out what the patient had. So if the differential diagnosis of a patient with scaly plaques is dermatitis versus fungal infection, what you should do is treat for dermatitis first with an appropriate strength of a topical steroid. So if the dermatitis is in a fold, you're not going to prescribe a super potent topical steroid. Topical steroids are scored on a scale of 1 to 7, with 1 being mild. That would be over-the-counter 1% hydrocortisone. With a 7 would be the super potent topical steroids like betamethasone or clobetasol. And so you make judgments about the strength of the steroid you should use depending on the thickness of the skin. So if you're applying and prescribing a topical steroid for the palms, that can tolerate a higher strength steroid because the epidermis and stratum corneum of your palms and soles is very thick, and therefore it takes longer for those steroids to penetrate. In contrast, the skin of the eyelids is there physiologically to help you blink, which means you have very, very thin skin. So you would never want to prescribe a strong steroid to the eyelids. You're really in that category of a class 1 or 2 steroid, like a 1% hydrocortisone. So one of the cautions when teaching dermatology I always have for non-dermatologists is take the strengths of these topical steroids very seriously, and as you prescribe, make sure not to give lots of refills on high-potency topical steroids to patients because they end up coming back a year or 2 later and you find out they thought it was an all-purpose cream that they could use on their face. So if a patient does not improve when you're treating for a dermatophyte, you will need to prove it with a KOH or culture. So in summary, back to thinking about dermatitis versus ringworm, dermatophyte, treat with the steroid. First, if they don't improve, it'll be much easier to find the hyphae of dermatophyte infection when they return for the second visit. So if the patient is immunocompromised, lesson 3 is think variant presentations of infectious disease. So these are also patients that you likely will need to refer But it's a signal to you. If you have somebody in your clinic that comes in and says they have a history of cancer, they've had chemotherapy, or they're an AIDS patient, they're immunosuppressed for some reason, you really have to take that skin exam much more seriously in terms of variation. And so you have classic picture here of shingles, and if you see in a dermatomal distribution ulcers or erosions, that also could be shingles. So the teaching point there is variation happens frequently when patients are immunosuppressed. So you consider bacterial, viral, and fungal etiologies in that immunocompromised patient. Variant presentations are common. Refer early. Teaching point number 4, never recommend neosporin or neomycin. So here's a patient who was applying a triple antibiotic that included neomycin to the eyelids. And once again, that eyelid skin is thin, which means that allergens are absorbed quickly. So you can get an allergen on your hands, that thick skin, thick stratum corneum. The allergen is not going to penetrate, and you have no rash. You then, as a patient, casually touch your finger to your eyelids, and you start rubbing, and that cream that has that neomycin or another allergen is going to break out the skin with a contact dermatitis. Here's a picture of a patient of mine that was using a cream, a lotion that had lanolin in it. So contact dermatitis, 2 days, it starts 2 days after you start the exposure. Neomycin is a really common cause of allergen. Many over-the-counter topical antibiotics have neomycin in it. It's a frequent cause of allergic reactions. Recommend for it. Number 5, rosacea. Very, very common condition. Typically seen in people of Northern European ancestries, particularly in people with Scottish, Irish, British ethnicity, also Northern Europe, Germany, and other areas. The presentation is typically a female, though it happens commonly in men as well, where you have facial erythema, sometimes flushing, and you can get red papules. So this is a patient that has kind of these continuous red papules forming plaques. So these are elevated blanching plaques. And here's one. It's a very large plaque that's studded with papules. So this is a little bit more confusing. Doesn't look like your classic rosacea. And here's even a more severe one with erythema, lots of pustules, papules. And this woman had this on both cheeks, quite severe. And here's a close-up, more pustules, deep erythema. These patients have been treated with their rosacea with topical steroids. If you treat rosacea with topical steroids, at first it gets better, and later it gets worse, and then some unwitting professionals then up the strength of the topical steroid, and it suppresses it some more, and then it comes back worse, and then they up the strength of the topical steroid again, and they get into this vicious cycle with the topical steroids, and the problem is a patient has rosacea. So the treatment for rosacea, if it's severe, is always oral tetracyclines, such as minocycline or doxycycline. Now, if you use much minocycline or doxycycline in your practice, you do have to spend time talking to patients about their side effects. So tetracyclines are photosensitizers, so you absolutely, this time of year, have to underscore with your patients that they need to use sunblock. Tetracycline itself is no longer available, so most of the time patients with rosacea or acne who need oral treatment are using doxycycline or minocycline. The other side effect that you need to mention with patients if you use minocycline is that minocycline can cause skin pigmentation. So that would occur after months of treatment. It's a good thing to warn patients pigmentation, typically occurring in their anterior shins or in the scars of the acne, and the scars of skin lesions. So you have to look out for pigmentation from minocycline. The other side effects of minocycline include headache and pseudotumor cerebri. So you will always ask patients been on minocycline for a while to ask that headache question. Metronidazole, also called Metrogel or Metrocream, ROSACEA, that can be very helpful, particularly those that have papules and pustules. It's not as helpful with patients that just have simple erythema or flushing. So to trigger rosacea, it's worth spending 30 seconds and giving a handout. We'll do this from VisualDx. Really important in patients with rosacea. The more diligent people are, the sun protector impactful the rosacea will be. I mentioned the metronidazole is also a treatment that combination of sodium sulfacetamide that treats rosacea as well, and the tetracyclines. In my teaching of dermatology to non-dermatologists, I'm personally stressing the problem of variation. So you all know that common things happen commonly in the saying, if you hear hoofbeats, think horses. Is the volume better now? And Jenny, can you just tell me if the volume's better?
Yes, sir.
Is that better?
Thank you.
Okay,
yes.
so the saying is, if you hear hoofbeats, think horses, not zebras. And so common things happen commonly. Variation of common happens second, and then rare diseases by definition are rare and uncommon. So in my teaching of non-dermatologists about dermatology, I stress this point because the errors that we see really have to do with variation of the common. So let's talk about some misdiagnosed cases here. And I'm going to go through these fairly quickly. I'm going to describe for you. Typically what I do is I have the audience describe and have our residents describe. But I'll do the describing for you, and I want you to think about the diagnosis. So here's an adult patient with thick, grayish, scaly plaques covering the toes and the distal dorsum of the left foot, somewhat on the right foot. And so there's some dense scale, not a lot of erythema, just some dense scaling plaques there that are confluent. So that's case one. Case two is a teenager that had widely scattered excoriated papules. So excoriations, or when patients scratch, and excoriations cause erosions where you lose that superficial part of the skin, the epidermis. So if you see excoriations, you usually don't have to ask the patient if it itches. You know it itches because there's clearly signs of that they've been scratching. So that's case two. Case three, also a young person, bilateral erythema of the palms. At the right wrist, you can see scaly plaques, a little bit of bloody crust right at the proximal palm. On the right hand, at the base of the left thumb, you see a big pustule. So in this patient, it's case three. Case four is a patient of mine I saw probably about 15 years ago, presented with about 8 or 9 red, smooth plaques and nodules in the axilla. I'm calling them nodules because, remember, nodules are firm and are a sign that the dermis is involved. They have a thickness to them. So you're feeling these, and these are very firm and hard, like cells are infiltrating the skin. And my thought was that this could be pseudolymphoma or leukemia cutis, like leukemia in the skin. So you'll see the kind of the bottom 2/3. You see my sutures from the biopsy, and the biopsy was rule out leukemia, rule out lymphoma. And when I got the result back, I was surprised. So the next picture is the side of a foot where there's a little snake-like, little curvy, thin little plaque, a little line of a plaque on the side of the foot. And so that is caused by this. So this is a picture of the scabies mite. So the scabies mite travels right underneath the stratum corneum and causes this little tunnel that we call the burrow. And so the teaching point here is that every one of those cases I showed you that were misdiagnosed are all scabies. So variation of the common. So I'll go back through them, and the first picture is a picture of crusted scabies that used to be called Norwegian scabies. So this patient actually has thousands of those mites on their skin. Those mites are not in the burrow. They're just living in little apartment houses in the stratum corneum, and you could take a blade or a glass slide, scrape this, and see hundreds of mites or dozens of mites. Very easy to find. The problem is that a lot of clinicians will take a look at a patient like this quickly and think it's psoriasis. That would be premature closure. That would be jumping to the wrong conclusion. So when you see thick scale, particularly in patients that are elderly or are immunocompromised, you have to think about that variant of crusted scabies. This is classic scabies. And the teaching point with this slide is if you scrape any of these lesions, you're not going to find the scabies mite. You have to scrape the burrow. This is a pustular presentation of scabies, and this is a nodular presentation of scabies. So the immune system reacted all these infiltrating lymphocytes in the skin, causing these thick red nodules here, and this is a known form of scabies called nodular scabies. This is the classic burrow, but you see I'm not showing you a picture of the web space. When a patient says they're very, very itchy, the first thing to do is look at their wrists and their web spaces. If you don't find anything, look on the side of the feet, the ankles, the margin of the soles, looking for the burrow. So there's the mite. And here's what some of the referring clinicians said. I never saw it look like that. So that's an expression of variation. They're looking for the classic. But I didn't see anything in the web spaces. Well, they didn't look at the alternative spaces I mentioned. I scraped for scabies and it was negative. Well, they scraped the itchy bumps, which are the allergic reaction to the mite, or they over-relied on history, asking if anyone else in the family had a rash. So here's an example of a patient that came to us that was treated for 3 months for dermatitis, but actually had scabies. And we had a medical photographer in my clinic. She took a picture, and you can see about 5 or 6 of these burrows on her palm. So that's a really good place to look, really important point. You often will find the burrows right at the junction of the palm and the wrist. So knowing where to scrape is key. And in typical scabies, you have hundreds of lesions and just a few mites. It's somewhere around 8 to 10 mites in a typical scabies patient with hundreds of lesions. You look for the burrow and you scrape properly at the end of the burrow and get that mite onto the slide. In crusted scabies or Norwegian scabies, there's hundreds, if not thousands of mites, and you can scrape anywhere. So that's another photograph of crusted scabies. And there's another picture of crusted scabies. The treatment for scabies, of course, is elamite cream. You have your patients apply for 12 hours. They wash off and they repeat in a week. They do all their bedding at the same time. They wash all their linen. And they also have their family treated at the same time. Number 7, herpes simplex. Remember your morphology, not the location. Not location, location, location like real estate. It's all about the morphology. It's the grouping of vesicles. So these are little vesicles that are grouped together. This was a patient of mine who was a woman that was pregnant, had these on her thigh. We were consulted. The obstetrician had no idea what it was. Telltale sign is right there, grouping of vesicles. Here is on the face, away from the lips, grouping of vesicles with some induration and erythema, little erosion at the center of the vesicles. On the palm, I keep coming back to that thickness of the palm. When you have blistering at the palm, the blisters don't raise up like they do on thin areas of skin. And this lesion, where you see a couple of grouped vesicles, has hemorrhage into the vesicles. So herpes can occur anywhere in the body. When it occurs on the palm or finger, it can look a little different. So here is a wrist with grouping of vesicles. Here's another picture of a palm with grouped vesicles. I've seen countless patients treated with Keflux and anti-staph, anti-strep antibiotics where clinicians, where doctors felt that the patient had a bacterial infection. Of course, herpes recurs at the same place. And we see these patients, they come in and they say, I keep getting treated with antibiotics, but it keeps coming back. Well, they're being treated for the wrong diagnosis. They're being treated for a staph infection, in fact, when they have herpes. So the key there is to recognize the grouping of vesicles. That's the sign of a herpetic infection. This is a herpetic whitlow. Whitlows are the term for herpes on a digit. They happen more commonly in people that work in healthcare, particularly oral hygienists and dentists are at much higher risk for herpetic whitlows. And then a very common location for herpes that gets mistaken for shingles is lumbosacral herpes. This is a known entity that we see over and over again where the patient comes in and says, why am I getting shingles so many times? And shingles tends to happen once in a lifetime, where lumbosacral herpes can be recurring. It can happen several times a year. It's often preceded by tingling and pain, where the herpes is going to break out. Once again, grouping of vesicles in the sacral area, and it often crosses the midline, which distinguishes it from zoster. So herpes, grouped vesicles. Okay, intertrigo, rashes in body folds. There are many causes, not one cause. So here's a patient with kind of brownish patches that are in the inframammary fold and the inferior aspect of the breasts. And you'll see in the axilla a minimally scaly pink plaque, sharply demarcated. And then in the inframammary fold, you'll see erythema and scattered papules, which suggest candidiasis. And then in a child or infant, this kind of fold is actually a sign of a strep infection. When you see this erythema and erosion in folds, you actually can have strep infections presenting in children this way. So look at all these different causes. This is erythrasma caused by Corynneum bacterium, which can be treated with a topical antibiotic. This is inverse psoriasis. This is candidiasis, where you have the satellite papules or pustules, and this is strep. So intertrigo has many causes. You have to think about them all. When using VisualDx, you can search the axilla and search morphologies and get a differential. So here are some of the common causes I already mentioned. And of course, it includes irritant dermatitis or allergic contact dermatitis. Top 10, number 9, annular, ring-shaped. A ring-shaped lesion does not always equal ringworm. So here's a non-scaly annular plaque, and that is granuloma annulare. And here is a ring shape to the medial edge of a plaque, and that's a form of lupus called discoid lupus. And this is a ring-shaped, non-scaly plaques, 3 of them, that are from a lymphocytic infiltrate. So, of course, Tinea Corporis or ringworm, that's something you're going to see frequently in the clinic. You should know the differential and not try to put a square peg into a round hole. If you see annular plaques that are non-scaling, you have to think of these other causes. So the annular differential diagnosis includes tinea, but also granuloma annulare, which I showed, discoid lupus, also sarcoidosis, and also urticaria or hives can present with annular patches. And of course, the tip-off with urticaria is how acute it is, with the patient saying the lesions just appeared or they're moving around. So in urticaria, the patches and plaques of urticaria do not last for more than a day. Your event can last for more than a day, but individual lesions do not last for more than a day. So Tinea Corporis is said to have a peripheral scale, meaning out at the edge is where you scrape for tinea. And, of course, you scrape and you look for fungal hyphae, and you treat Tinea Corporis with antifungal creams like clotrimazole, ketoconazole, miconazole, terbinafine, and naphthene. And, of course, steroids will make it worse. The last of the top 10 is new solitary lesions, and the slide says be careful. And there's always these humbling things that happen in your career. And I've been doing dermatology for 25 years, and we all make mistakes. And the key thing I tell our students and residents is you just have to learn from your mistakes and establish feedback loops as best you can to realize what happened to your patients, because that's how you learn. That's how you become a better clinician. So here's a patient we saw with a very innocent-looking erythematous papule. Had this little erosion and brighter red kind of hemorrhagic area at the center. This was biopsied and found out to be an amelanotic melanoma. So no pigment, but it was a melanoma. So when you get one of these and you do the biopsy and you send it in and it comes back melanoma, it's humbling because your mind was not thinking melanoma. And so here is another picture. This was biopsy thought to be a basal cell carcinoma, but actually came back melanoma. So amelanotic melanoma has a differential that includes basal cell, squamous cell, other skin tumors. They all need to be considered. The key teaching point is when a patient comes in, they have a lesion that does not neatly fit in a category, don't try to shove a square peg in a round hole. So we know that patients love to have answers and precision, but I often say to patients, look, we're not sure. It's ambiguous. It's going to take some time to figure out, but we will get to an answer for you. So those are the top 10. In this presentation, I hit this theme of variants of common diseases. Variation, I mentioned location around herpes. On the left is the common presentation on the lip. On the right is the back of the leg. We covered that. I didn't talk about skin color variation. Very, very important point. We have a lot of disparities in healthcare where people of color do not have access to care. And we talk about issues like that, but we also don't cover the problem of disparities in knowledge. And one of the key features of VisualDx is we've been very purposeful of having imagery of disease in people of color. And so this slide is all about how subtle redness or erythema or purpura can be in brown skin. So if you have redness or purpura, signs of inflammation, it's going to present as darker brown in brown skin. And then on the right, vitiligo can be very subtle in patients with very light skin. So skin color causes variation. We covered immunocompetent, immunocompromised, using scabies, and we didn't talk specifically about severity variation. The patient comes in with something on the right. Anybody knows something is quite wrong there, but really you're clinicians because you want to try to help people with early disease. Things can be subtle. You know, basal cell cancer occurs frequently in fair-skinned people on the face. It's very, very important to palpate these lesions, illuminate them, and consider basal cells, particularly in people that have had a history of a basal cell before or squamous cell. And then the other form of variation is when are you seeing the patient on the timeline of disease? Are you seeing them early, in the middle, or you're late? And, of course, shingles or zoster would be a great example of that. Patients often come in with chest pain, and they have no rash, and then 2 days later they break out with the classic dermatological vesicles. They might first just have blotchy, grouped erythema, and then the vesicles crust, the crust go away, and then they have scars. So always be thinking about where are you seeing the patient on the timeline of their process. What's the primary lesion? Was there a vesicle here that's now gone because they scraped it off and it's now just eroded skin? And your differential really is about the vesicle, not about the erosions. So segueing now to VisualDx, you all have access to VisualDx. There are a number of benefits for you at the Little Clinic. I see patients on Monday morning with residents. We're always using VisualDx, and one of the uses is really to review the quick therapy and alternative therapies for a condition. So it's written by dermatologists with you in mind. So the writers are not supposed to write to the level of dermatologists. They're writing to the level of primary care. We're trying to think about how do we help clinicians at the point of care. There's over 40,000 images in VisualDx, and you can get CME credit for every search you do in VisualDx. There are also patient handouts in English or Spanish. So people use VisualDx by searching by disease. They share images with patients. They solve complex cases. They review medication adverse events. And as I mentioned, you can visualize disease in people of color. I'm going to jump over to VisualDx now. And so you'll see the homepage of VisualDx. And I'm not sure which homepage you're using at your clinic, whether it looks like this or not. I know that we have a custom homepage at some of the Little Clinic locations, or we did. But this will certainly demonstrate the key points about VisualDx. And so I think we'll start with the simplest and move to a little bit more complexity. I mentioned patient education. Well, let's use that poison ivy example again. So I type in poison ivy. You'll notice it comes up under build a differential or under diagnoses. We're going to choose under diagnoses and bring up the writing for poison ivy. A family doc had a patient in the exam room that the clinician knew immediately the patient had poison ivy. Without the help of VisualDx, the patient was arguing with the physician saying, there's no way this is poison ivy. I was all over the internet myself, and I didn't see any pictures where poison ivy caused such large blisters. So in seconds, they had a picture up in front of the patient showing, yes, poison ivy can cause large blisters. And then the physician just paged down, and you'll see there's pictures of poison oak and poison sumac, and at the very bottom, pictures of poison ivy. Enlarged the image, swiveled the monitor to the patient, and then went over to the information for patients, and then you can either print or email that to the patient. So when I hit print, the last image that I looked at came up in the handout. I can change that image if I want to a different image, including an image of the rash. So you can print that, or you can turn to the patient and say, what's your email address, and email that handout to the patient. You also can change the handout into Spanish now. So you can print or email a handout on all the common dermatologic diseases in English or Spanish. Remember, I made that point in the lecture about management of poison ivy. So under management pearls, the authors of the text have put in, do not prescribe a 6-day course of quickly tapering steroids, and then right below is the therapy for poison ivy. So every disease in VisualDx follows handbook-length text of a synopsis, the codes, what to look for in an exam, diagnostic pearls, the textbook differential, not the differential you created with the software, best tests, management, therapy, and their references in there. So that was a search by diagnosis and highlighting how you can get to therapy, highlighting how you can provide patient education. I also mentioned how helpful this can be for checking on a medication reaction. We had a advanced practitioner that had a patient complain of some lesions on her arm. So the clinician entered that the patient was on naproxen because at the last minute the patient had said, oh, by the way, I take naproxen once in a while. Do you think this causes the problem? And so enters naproxen and then goes to skin lesion type and enters as a blanching patch and hits the green, view this differential, and it jumps you into the drug-induced tab, and you'll see at the top there's a bunch of diagnoses, but the patient had these round, kind of quarter-sized or larger patches on her arm. The clinician got curious, clicked the lower right-hand corner to see more images, started scanning down, realizing that large kind of circular round patches are the hallmark of fixed drug eruption. Click the image, patient's looking over the shoulder and says, yep, that looks just like me. I do take naproxen once in a while. The synopsis explains these are common cutaneous adverse drug reactions. They reoccur at the same body location every time you're re-exposed to the culprit drug. Common things happen commonly. These are triggered frequently by nonsteroidals. In any diagnosis that can be triggered by a medication, in VisualDx, in the table of contents, there's a drug reaction data link. You click that, it gives you the alphabetical list of all the medications, including the class of medications, which presents initially alphabetically, but you can click citations and it will reorder the list and show you which medication or classes of medications have the most citations. So NSAIDs have 57 case reports, and you'll see down, as I page down, you'll see that the number of citations go down, but you'll see there's naproxen. I click the 13, it shows me the evidence in the literature that naproxen can induce fixed drug eruption. So there's an exhaustive database of medication to drug reactions. And so you can go into VisualDx and search a med, or you can search a condition. So if you suspected that the patient was beginning to have erythema multiforme, and we went to erythema multiforme, you can search erythema multiforme and then go to drug reaction data and check the med that you're thinking might be the culprit, or you can click citations. Really important part of VisualDx. I also mentioned variation in disease when the patient is deeply pigmented. So let's go over to shingles. I use that as an example. So I'll put in shingles, and I'll go up to view all images, and I'll click filter images, and then I click skin pigmentation, and now I'm viewing shingles in people of color. And so this is enormously helpful when you have a patient of color. You want to give them a handout. You want to show them that you're thinking about them. They really respect that you've taken the time to share some images with them. But we're close to the hour mark, and I did want to leave time for questions. I have one more demo, which is just to say, if you do search the word rash, there is a process that can help you with a differential. So you search rash, it asks you to put in the type of lesion. So let's go ahead and say it's a vesicle. Let's go down to location and say it's on the hands. It's actually on the fingers. Let's put in some symptoms. There's fever. It itches. And hit view the differential. We have this tab result. Consider first, consider second, emergencies, infections, drug-induced, and view all. It defaults me into the common things first. So there's zoster, and you'll see others that are in here. So you can get into the drug-induced, the infectious, the emergencies, consider second. VisualDx has expanded beyond dermatology. The focus of this presentation was Dermatology 101-201, for you. We didn't focus at all on using VisualDx for the differential of internal symptoms. That's included in VisualDx, and there's certainly many, many YouTube videos on that. Our support team at VisualDx, I believe Amanda's on the phone, will be pleased to send out training links, and we can conduct more training webinars.